Hi, my name is Norm Eisenstein. I'm a neuropsychologist, and my area of expertise and my area of interest really is cognitive decline. But Stan asked me to come here and talk to the group, and I've done this before because my son was diagnosed with an astrocytoma probably about 10 years ago. So he asked me to come talk a bit about something about how the brain works, what neuropsychologists do, and also I would be very happy to talk about my experiences and Nick's experiences as well. So I really hope there's a lot of questions and a lot of discussion, because otherwise I will just drone on, and that's really not as much fun for me, and I don't think it's as much fun and as interesting for you. Let me say something first about what is neuropsychology, and I know that Dr. Bloomfield, who was speaking before, talked a bit about the role of neuropsychologists perhaps before and after neurosurgery or treatment for brain tumors, and actually treatment for a lot of other things. And Dr. Bloomfield showed some terrific slides about all the very elegant things that people are able to do now to image what's going on in the brain, find out where the fiber tracts are, how they've been pushed out of the way by tumors or by other processes, find out something about the individual differences between each of us and across gender as to how our brains are organized. But this is really something very new. And up to about 1950, there was really not much of any way to take some kind of picture of what was going on in the brain. And what people used to do is they used to do two things. They used to do pneumoencephalograms, and what they would do is they would induce air into the space around the brain and get some idea of what the outside of the brain looked like. And they would do contrast x-rays, where they would inject dye into the blood vessels, and that would give you some idea also of what was going on in the brain. So before 1950, or the early 1950s, when CT scans were first invented, the only way that someone could actually get some idea of what was going on in somebody's brain, what worked, what didn't work, where there might be pathology, where there might be damage to somebody's brain, was by doing some kind of testing. Now, what happens when somebody has a brain tumor? Well, it depends on where in the brain the tumor happens to be, which tracts happen to be affected by the tumor. And the brain as a whole reacts to having a tumor. Now, neuropsychologists typically talk about 5 areas of functioning. Typically talk about attention and concentration. They typically talk about memory, perception, how we see and hear and feel the world around us, language functioning, and something called executive functioning. Now, all of this sounds kind of fancy, and I was thinking when I was listening to Dr. Bloomfield's talk that most of this has really very little to do with finding out whether somebody has a brain tumor. And I think that probably most often people are identified as having brain tumors the same way that Nick was. You have a situation where something seems to be wrong with someone, and you take them to the emergency room. And I remember when we took him to the emergency room, I was not thinking that he had a brain tumor at all, which is sort of interesting to me, considering what I do all the time. One of the colleagues at the hospital where I work, who I had talked to about the problems he was having, said to someone else, but not to me, "Boy, I hope he doesn't have a brain tumor." But he presented with what is a very typical presentation clinically for people having brain tumors, in that he had a terrible headache, he had projectile vomiting, and he had something in the back of his eye, in his retina, which is called a choked disc, which are typical indications of increased pressure within the brain. Does anyone have any questions, or am I just going to? I'm sorry? Something called a choked eye. When you look in the back of the eye, you can see changes in the disc in the back where the optic nerve is. And those are the three typical symptoms of a brain tumor. Now, what are some of the things that are important about where the tumor is in the brain? Is it on the left side or the right side of the brain? Typically, for people who are right-handed and for males, language functions are located in the left hemisphere. And this is something Dr. Bloomfield was also talking about in a different sort of detail. There is an area in the front of the brain called Broca's area that is involved with controlling the motor apparatus of our speech. An area posterior to that in the temporal lobe called Wernicke's area, which is involved in meaning and the production of speech and the more complicated aspects of speech. There is the motor strip that Dr. Bloomfield was talking about. There is a sensory area in front of that. And then there are the pathways for vision. So this is a diagram of a brain. The anterior part is pointing to your left. The back of the head is pointing to your right. The primary motor area, which Dr. Bloomfield was talking about, is in the middle. The area in front of that is a sensory area. This is a drawing from of the primary motor cortex, and this is derived from Wilder Penfield's work, and this is a representation of where our motor activities are laid out around that strip of the brain there. These are some of the broad areas in which people have deficits, don't have deficits. I'm really looking more for questions, folks, and more of a discussion.
Regarding the hippocampal area, in terms of memory function, other than neuropsych test, are there other ways to determine how much is affected, in what ways, more specifically than generally we think this, we think that, but we're not really sure?
I think, you know, with neuropsych testing, with cognitive testing, you can get a lot of fairly detailed information, a lot more than general information. I mean, one of the things that a neuropsychologist should be able to tell you is that, first of all, whether you're having a problem with attention and you're paying attention to, and you're able to focus on what you're supposed to learn. One of the things that I see often clinically, because I see a lot of older folks, is they have problems with their hearing. And if you have a high-frequency hearing loss, certain sounds of speech tend to be garbled, and very quickly you stop listening to them. And when you stop listening to them, needless to say, you don't remember them. So, you know, I think you can get a lot of, particularly with a neuropsychologist, you can get a lot of very detailed information as to what the memory problems may be. Are these memory problems having to do with the understanding of language, with a sensory problem having to do whether you can identify the sounds of speech in some sort of meaningful way, whether you can retrieve the information, whether you have a sensory problem, as on one of Dr. Bloomfield's slides, he was talking about alexia and agraphia, an inability to recognize letters, an inability to recognize words. And you can get all of that information. You can get pretty specific information. So these are some of the things you can get from seeing a neuropsychologist. Now, when Nick first had the surgery, even though he presented with these problems of vomiting and nausea, and a choked disc, he presented with some other problems as well. He presented with visual problems. He was unable to see things in the right side of space. And this was because his tumor sits, and this is one of his films, sits right in the midline and really sits very close to and interfering with the optic chiasm, which is this area which is the area in the middle labeled number 3, which is where the nerve pathways from the back of the retina go through and cross and go to opposite sides of the visual cortex eventually. So he was unable to see things on the right side of the world because of where the tumor is sitting right in the midline. What's on both sides of the brain? Yes, but it's sitting right in the midline where the fiber, where the tracks pass and cross over and go back to the lateral geniculus and then to the visual cortex. It's on both sides, but it's bigger. Yeah?
No, I'm just saying that it depends where it's set, right?
Yeah. Yeah. Well, this is really my point, is depending on where the tumor is. Now, the neurosurgeons have gotten more and more elegant about how to approach these things, how to avoid fiber tracts. And, you know, it's really exciting to listen to the newer technology all the time. But you're right, this is, you know, where the tumor sits, how high in the brain it is, and this is fairly low. And interestingly, I think that if you look back, because hindsight is always great, Nick was working where part of his job involved driving a truck, and he kept having accidents, and the accidents seemed to involve people coming from the right side in front of him that would either hit him or he would hit them. And in hindsight, probably that had something to do with the brain tumor that was developing. But, you know, who had any clue at that point? Yes?
Being experienced, age-like already. My tumor certainly began with a focal seizure. But I believe the neurosurgeon even said to me, I was writing down every day, something's going on, something's going on. It's different than how your body works. So all of a sudden, it's just like not just pain in the arm. It's like, gee, I just feel funny. And the neurosurgeon who knew, he said it's very, very normal to have diagnosed patients, newly diagnosed, where they had journals. I was almost embarrassed. Every day I had a journal, like a diary. My cheek twitched, this, that, this, because you don't know what's happening to you. It's not a toothache.
Can you say anything now anymore about what felt different, what that was like for you?
Well, for me, was at the first time I had what's called a focal seizure. My tumor was on the right frontal lobe, which addressed that, the muscles there. And actually, it would wake me up at night. So all of a sudden, twitching. I think it's because I partied that much and drank that much, and oh, it's okay, and I just go back to sleep. But afterwards, I said, this is not right. But I actually made a journal. The journal is this thick, and I was embarrassed to go to the doctor to show it. He goes, oh no, Debbie. Many patients write journals because it's a strange, unusual thing that's going on in your body. And that kind of sat with me. Can you hold it? Sat with me. That it's a normal thing for progression for brain tumors, newly diagnosed. Because it's not something that's unusual.
I don't know how unusual it is. I think that one of the things that that we say in neuropsychology is everybody's brain is different, and everybody's brain, maybe not so much everybody's brain, but how it reacts and what happens is different because we're all individuals. So you are articulate and able to keep a journal, and I think that that's terrific, and I really appreciate you sharing that with us. Not everybody does that. Not everybody is so reflective about what's happening with their body.
Yes, even
not
if-
everybody pays
yeah,
attention
no,
to these
that's
things.
true.
They're not
That's
articulate.
true. No. Even the second time around,
Hmm.
I was reading Newsday, and I was taking the letters and making new words. The newspaper was quite interesting. And the news was really good. But it was just unusual. And basically, it's just, the body was just not functioning normally. It was not odd. It was not unusual.
Yeah, I think that's great. I remember talking to Nick before I brought him back down home from Massachusetts where he was living, and he could not explain what was going on with him. And you know, in all honesty, I guess he was 25 at that point, you know, the things on my list of what might be wrong with him was that perhaps he got into drugs, perhaps he was having a little bit late onset of a psychiatric disorder, but it never occurred to me that he was experiencing the symptoms of a brain tumor.
Norman, I think I've talked to you about this before, but my first brain surgery in 2006, I had a tumor taken out of my parietal lobe on the right side. And apparently there was near some, I was told, optic nerves by my surgeon. And I've lost most of my peripheral vision. Does that have anything to do with some of these optical tracks that you're talking about, the peripheral vision?
I would guess, without knowing more, John, I would guess it has to do something with these tracks labeled 4 here.
Okay.
Yes.
And you also mentioned that neurosurgeons are making remarkably new headways into surgery and I guess maybe protecting certain nerve regions. Any of this repairable?
Repairable, I don't know. You know, the question, the last time I gave this talk, people want to know about neuroplasticity, which is how much some other area of the brain takes over some other function. And this is really a hot topic. It's really been a hot topic for a while now. The initial idea about neuroplasticity, interestingly, comes at least in part from a psychologist named Diamond who did studies with rats. And what he did is he gave one group of rats a very environmentally enriched environment and a lot of things to play with, and another group of rats a much less enriched environment. And when you looked at the brains of the rats in the enriched environment, there were many more connections and more neurons and more complexity and that sort of thing. So repairable? I don't know. I hope that it is at some point. Yes? Yeah.
That's a very interesting question, and I think we do see recovery. Dr. Bloomfield talked about that. We do see that, and some of that may just be decreased inflammation after surgery, or about 90% of people with deficits get better, but if we cut a track, then it's very limited ability to repair itself. But something that we're looking to quantitate and study using the tractography. But certainly there is some ability to recovery. We see it more in kids. Kids have an amazing ability to recover.
Yeah.
I'm sure it's a very complex process involving stem cells or remyelination and so on. What I want to ask is, if you go to the bookstore now, if there's such a bookstore, or go to Amazon, you'll see, and you look brain, you'll see your brain on this, the female brain, becoming a better economist through neuroeconomics, using your brain to get yourself organized. It's almost a popular psychology thing, how to maximize your full potential. And there's a company called Lumosity, which is on the airways all the time. They're
I
actually
get a lot of questions about lumosity at work.
Yeah, the Harvard neuroscientist has proven that. So basically, it's based on a metaphor that your brain is like a muscle because it has these fiber tracts and you can build it up. There was a classical study done, published in London on the taxi drivers. You probably know about that.
Mm-hmm.
Which they, in London, a very rigorous course, takes about 4 years of training to become a taxi driver, and they have to know everything, like how to get from Buckingham Palace to Charing Cross, and they're tested. And they did MRIs on these cab drivers, and the ones that passed this rigorous course, they actually had a increase in their hippocampus. So this, as adults, and so there is some amazing way the brain can rebuild itself with instruction, with work.
Yeah. The most fascinating, I'll get you in just a second, the most fascinating things about neuroplasticity are there are a number of groups, there's one at Johns Hopkins and there are a number of others in the country who do these hemispherectomies for intractable seizures in children. And they take out an enormous amount of tissue. They take out almost 1/2 of the whole brain, and the space ends up being filled up with cerebrospinal fluid. And if you look at these children later on, they are nowhere as impaired as you would expect them to be, having taken all this brain tissue out. But this is children, first of all. This is not necessarily adults. And as Dr. Brem was saying, there is an upsurge in companies who were trying to, like Lumosity, who are trying to sell us things that are going to hopefully keep us from getting Alzheimer's disease and other kinds of cognitive decline. Now, whether this works or it doesn't work is going to be very difficult to tell. Part of the problem with Lumosity and these other things is that they teach people the tests that I use to see whether you have Alzheimer's disease. So if I use a test that requires you to do something like read words in black and white, then read words in color ink, then tell me the color ink, and that's what you practice doing all the time, your performance is going to improve. But it's not clear to me whether this is going to really improve your memory, guard against Alzheimer's disease or something like that, or just how to teach you to do better on the tests that I might do. And then the other part, you know, at the other end of the spectrum is that whether we grow new brain cells, and Dr. Brem was talking about the, you know, the taxi drivers. This is something that's really an area of a lot of interest at this point, you know, and people are excited about that, and who knows what will happen. I hope it works.
I have two questions.
Sure.
One, I took my husband to a neuropsychologist, and he's not going there anymore, but I was wondering what the purpose, what... Good neuropsychologist? He was not. He was more interested in himself, but what actually is your, what do you do with your patients? That's number one. Number two, if neuropsychology, cognitive therapy is so important, unfortunately, Medicare only gives you so many hours, so much money per year to use on, and cognitive speech therapy goes with physical therapy, so it's the two together, and occupational. And with brain tumors, it's not like you got your knee operated on, and so you might need a certain amount of time for therapy. Brain tumors, according to our doctor, should be constantly, brain tumor patients should constantly have therapies. So my question is two. Number one, what do you do?
Okay.
And number two, to help brain tumor patients. And number two, is there any way with this cognitive therapy that you can get it more than what it's supposed to be? Okay.
First, let me see if I can figure out what I do and explain that to you, okay? So I'm a psychologist, and I've spent a lot of time and had a lot of training, hopefully, and know hopefully more than a bit about how the brain works. And what I should be able to do is I should be able to spend some time testing you and talking with you and learning about your life and trying to help you figure out, for example, what kinds of rehab needs you might have. For example, perhaps you've had damage to the right side of your brain such that you have difficulty recognizing familiar places, and you get lost all the time. One of the things that you could do with that is we could teach you how to recognize things with the other half of your brain, verbally. Maybe we could teach you how to use a list, how to make a list of landmarks. I think that, and maybe I'm getting myself in trouble here, I think that there may be some tendency for men to look at directions and women to look at landmarks. And you could oversimplify that, and you could say that maybe men are doing this in what might be called a left hemisphere style, looking at details, and women might be doing this in a more visual, perhaps a right hemisphere style, and this is a gross oversimplification. But maybe if you're going out and you're getting lost and you can't find your way around, maybe I can do a couple of things. Maybe I can say to you, yeah, you really are having trouble getting lost. Maybe you need to get a GPS. Maybe we can buy you a GPS. Maybe your insurance company will buy you a GPS. Maybe we can teach you how to look for street numbers and directions and to write down directions. And the very act of writing down directions is going to help you learn this in a different kind of way. So that is one example of what a neuropsychologist might do in a rehab kind of setting. Another thing that a neuropsychologist might do is a neuropsychologist... 9 minutes. Okay. I'll talk fast. Another thing that a neuropsychologist might do is work with someone like Dr. Bloomfield, sometimes even in the operating room, to help him understand as best he could what areas of the brain are going to be affected by what he's going to do, help him map things out. That's another thing that a neuropsychologist might do. Neuropsychologists work very often in head trauma programs and help people plan rehab. Neuropsychologists might help you understand, can you go back to work? What adaptations cognitively might you have to make to go back to work? Can you go back to work in a different kind of setting? Maybe something that plays more on your strengths than on things that may be deficits to some extent. Another thing that neuropsychologists do that I spend a lot of time doing, because my particular expertise and my particular area of interest in cognitive decline is I see people half a day, all week long, who think that they have problems with their memory. Some of them do, some of them don't, some of them have Alzheimer's disease. So those are some things a neuropsychologist does. Now, if you look at a cleaner model in some ways than a brain tumor, where you don't have this sort of ongoing pathological process that needs to be treated in an ongoing way, and you look at head injuries. When somebody has a head injury, there are certain fairly well-defined things that happen. And after they have this head injury, God willing, they get better. Now, you can probably enhance their ability to get better with cognitive therapy. I don't know, and some of my dear friends who are speech pathologists do this. It is very difficult to show that that is an efficacious treatment because the person is already getting better. As Dr. Brem was saying, and I think the other speakers have said today, that when you have surgery for a brain injury, after that you start to recover and you get better. You know, my son did a lot better until the tumor recurred. I mean, there was an enormous amount of improvement once the initial consequences of having the surgery started to reside, the swelling and this and that and so forth, and these effects at a distance. So, the reason that it's hard to get someone to pay for cognitive therapy is twofold. First of all, it is difficult to demonstrate that it works. Second of all, the insurance companies look at this from a business point of view, and they're looking at this, how is this going to reduce my expenses in the future? I don't know that the insurance company has necessarily the same goal that you and I have as consumers. they're interested in running a business, and you're interested in getting help throughout your whole life. And you may need it, and you should be entitled to it, but you're going to have to fight with them. Did I answer your questions? Okay. Yes, ma'am.
Should I speak? Hi.
Okay.
Yeah, in terms of someone returning to work, and you talked about cognitive therapy, is there some sort of executive reasoning testing you can do if someone is in fact an executive and would like to return to that type of work? So the logic and all the rationalizing and that kind of processing is really important, but they want to be prepared on their return. Is there testing you can do, and is there any online resources or practicing that can be done?
Well, I think that you'd first try to figure out what kind of problems someone's going to be having, what kind of deficit someone is going to be having. People have problems with fatigue after surgery and after brain tumors. Are you going to be able to attend and concentrate on the material? The problems with attention and concentration after any kind of insult to the brain are almost ubiquitous. They're just so common. Beyond that, what might be some of the other problems that somebody might have? Writing things down, working in a meeting. It's not at all uncommon to find that when you're in a meeting and a lot of people are talking and your brain is not quite working as well as it might have before, that it's very hard for you to sort out who's saying what and what's going on. And you might be more distractible. So all of those things are something that in an ideal world, maybe not the neuropsychologist that you saw, but a neuropsychologist should be able to do some testing with someone, find out what the demands of the job are, help someone plan a rehab program to address those needs. And to the extent that those needs may not be able to be addressed, help someone adjust to different challenges.
Regarding neuropsych tests, and also Dr. Brim mentioned the first question I have is...
One second, we can't hear you. Everybody else wants to hear you too. Thank you.
Regarding a neuropsych test and the hippocampal issue that Dr. Brem mentioned, with the hippocampus, if it increases in size, is it bilaterally increasing? And if one were removed, would one side necessarily be able to increase with work in the same way as both sides might? That's the first issue. The second issue is a neuropsych test showing functionality like hippocampal functionality with memory. Specifically, is it able to decipher which side is doing what in terms of certain specific functions, and can necessarily the other side take over functions if it's a deficit on one side, if one side's removed?
Maybe. Maybe you could get some idea if it's this side versus that side, but the whole question of which functions in the brain are lateralized is something that is continuously evolving. Typically, speech is on the left side. There are other functions that are on the right side. If I see someone who has a problem with spatial memory and remembering drawings and locations and things like that, I tend to see that as a right hemisphere dysfunction. But by the same token, people who are non-right dominant have more of these functions represented bilaterally. Women have more of these functions represented bilaterally. There are anatomical differences in areas like the planum temporale in women. There are differences in spatial abilities in women that you don't see in men. A lot of this is very individualized. If you have a left hemisphere stroke, if you have a left MCA stroke, which is probably fairly common, you are probably less likely to have an impairment in language in a male than you are in a woman. There's some data that I saw that you're less likely to have a language impairment if you're a musician, because there is some difference in the representation of these different abilities from one side of the brain to the other. So, if I wanted to know which half of my hippocampus was better, and memory is not isolated to the hippocampus. There's a lot of other structures that are involved in memory as well. You know, maybe I would see someone about some testing. Maybe I might also see someone about functional MRI and maybe some other imaging, and I would talk to some other people.
Yeah, well, I did functional MRI, I did a water test also. But there are still questions, specifically how much the right side's working, which is where the tumor is, versus the left side. And there I have bilateral memory. I was actually slightly, during the test, it was actually slightly better on the right side. The question is, if you remove the right side, how much effect does it really, how much of an impact does it have on your function that the right side might still be doing? And how much can be relearned on the left side? And that's, nobody can seem to answer that,
Yeah.
I guess, right?
Maybe another minute and a half of answering. We're running way over the cost.
I don't have an answer for that. I mean, I think that's,
What was the result of what you mentioned you had a water? Yeah, the water was actually 912 on the right, 912 on the left, 1112 on the right. I know it's crossed there on the left, so I'm not able to see it close, but it was bilateral.
I'm getting all these stop talk. Yes, John.
Well, I am a prime example of what we spoke about. I am a real live example of what the question is. I've just gone through brain mapping surgery, 2 surgeries, July 24th and 31st. I've had most of my right temporal lobe removed, hippocampus and the amygdala has been removed. I was told my whole memory on my right side is gone from this surgery to hopefully remove the seizure focus that I went in for. And so far, I've had no seizures. But I feel as though nothing's happened. I am functioning, I'm remembering, and they're telling me my memory has been taken out. And it's incredible. I just feel like I said, nothing has happened. I just can't believe the things I'm remembering. I think I'm blowing my wife off her feet because she's asking me questions and I'm coming up with answers from... I've been told that the left hippocampus is going to take over and operate or function and allow me to function the way I used to. And something strange is happening. It's actually amazing. But I've been told that my brain is under construction now and it will get better. So
I think that's great, and let me add just one other note. I spent a lot of time working with people who had head injuries, and I still see them. And people will tell me, boy, you know, it's been 20 years since the head injury, and now my brain is only starting to work the way it used to. So our bodies are always changing, our personality is always changing, our brain is always changing. And that's probably a good place for me to stop talking.